So I want to acknowledge with humbleness and gratitude that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, and the Métis Charter Community of the Lower Mainland region. And each of you, somewhere in this province or country, are watching this from your territory. And in our attempt to improve our understandings and fulfill truth and reconciliation, we should all dedicate learning more to the land that we're on so that we can actually cherish it and the peoples past, present, and future more. With that, I'd like to hand it over to Maylin Bissonnette, who's our head of pathology, renal pathology, to introduce our guest speaker. Over to you, Maylin.
Thank you. Good morning, everyone. I'm pleased to introduce Dr. Lihong Bu, Assistant Professor in the Department of Laboratory Medicine and Pathology at the University of Minnesota, where she is a pathologist on both the medical kidney and genital urinary services. So Dr. Bu began her medical career in Shenyang, China. She then received her PhD in neuroscience at Brigham and Young University in Utah and completed a postdoctoral fellowship at Children's Hospital, Boston. She then went on to finish her anatomic pathology residency at UT Southwestern in Dallas, Texas, and her medical renal pathology fellowship at Cedars-Sinai Medical Center in Los Angeles, California. So she has numerous peer-reviewed publications, and today she's going to be speaking to us about her work on galactose-deficient IgA1. So over to you. Thank you.
Thank you for the introduction. Let me share my screen. Okay, so I have been working on galactose-deficient IgA kidney biopsies for the past several years, and I'm very happy to share our experience with the group and would like to hear your feedbacks and comments. So I have nothing to disclose, and I would like to start the presentation with a challenging kidney biopsy. Because I'm a practicing pathologist, usually I'm only doing translational research, and our research focuses are inspired by the biopsies we received through the service. And then I'll do a very brief review on galactose-deficient IgA1. And then lastly, I'll cover our recent study on galactose-deficient IgA1 in lupus patients. Okay. So the case I'm sharing with the group, we publish as a case report. So this is a biopsy from an 11-year-old girl. She had a diagnosis of lupus 3 months ago. And at the time of diagnosis, she had a clinical presentation, and then she has positive ANA and double-stranded DNA. She was treated with steroids and hydroxychloroquine. And at 3 months follow-up, so at the time of biopsy, she had no hematuria, she had no proteinuria, and renal function was normal. So at the 3 months follow-up, she was found to have 0.75 gram proteinuria, and UA showed 3 red blood cells. Serum creatinine, complements, and all the serology at the time of biopsy was normal. So we still did the biopsy. The light microscopy actually is very, the findings are very, very mild. The only finding is segmental, very segmental mesangial hypercellularity. No endocapillary hypercellularity, no crescents, no segmental sclerosis or any chronic changes identified on the biopsy by light. And on the IF staining, so we do see positive IgG deposits mainly in the mesangium, as well as IgA. However, the IgA is brighter than IgG. IgM is also positive, and then C1q or C3, it may not reflect very well on the screen, but they are positive, just they are very dim, okay? And then both the kappa and lambda, they are positive. So looking at this staining pattern, depends on how we view it, right? Yeah, either we can call, oh yes, there are staining for all of the GAM, C1q and C3. So this is a full house pattern, right? But on the other hand, IgA is the brightest staining. So then we look at the EM only showed electron dense deposits in the mesangium and no subepithelial or subendothelial deposits identified, and no tubular reticular inclusions were seen in the endothelium. And also, I forgot to mention on the IF staining, no tissue ANA or extraglomerular deposits are identified. So this seems quite a mild finding. However, it's hard for pathologists. How do we make a diagnosis? Do we call this IgA nephropathy based on the IgA is the most strongest staining? Then this is okay, it's a co-dominant with IgA and IgG, mainly in the mesangium. On the other hand, common things are common. The patient is a lupus patient, and the patient does have a relatively, we can still call it a full house staining. It's just IgG with IgA co-dominant. So really depends on how we view it. And then, so for lupus nephropathy, which is, as I said, it's very common in lupus patients. So we, as a pathologist, I think in 2012, we were granted the power to make a diagnosis of lupus nephritis if on the biopsy, it shows the features that are compatible with lupus. And then in the presence of either positive ANA or positive double-stranded DNA. So that kind of like in the past is a pathologist will correlate with a clinical diagnosis of lupus, then we call it lupus nephritis. However, with this power, then we are, how do we use this power to call, do we really call a lupus nephritis in a patient without other symptoms, just based on the positive ANA? So the group of investigators from Columbia, they did this study on the sensitivity and the specificity of pathologic findings in lupus nephritis. They identified the 5 features, including full house staining, including GAM, C1q, and C3, which is what we are all aware of, and then strong C1q, tissue ANA, extraglomerular deposits, and endothelial TRIs. So with these 5 features, if we are seeing more than 2, the more of these features we are seeing, the higher the specificity if we call it lupus nephritis. For coming back to this case, then we only have the first feature. We do not have the rest of them. So it's a weaker call for lupus nephritis, right? But on the other hand, lupus nephritis has been recognized for a long, long time. So even the renal involvement, it was well accepted back in 1950s. But when we talk about IgA nephropathy, that's a different story. Because for IgA nephropathy, if we look at it, it was not recognized until 1960s. And then for the pathology of IgA nephropathy, which was well studied by Charles Jeanette at UNC, at the time, which is 1988, when he published the study, when we look at the details, he was using the criteria, say IgA staining, dominant or co-dominant in the mesangium, but the grade of IgA is 2+ or greater. And then there are 2 other conditions. One is C1q got to be grade 2+ or less. And then no evidence, the patient has no evidence of lupus. And then when we look at the patterns of these IgA nephropathy and then lupus nephritis, actually they have different patterns. For a classical IgA nephropathy, it's IgA dominant, and then it's not uncommon that we can also see IgG and IgM deposits, but low C1q staining, and kappa lambda shows a predominance of lambda light chain. In contrast, for lupus nephritis, the brightest are IgG and C1q, and kappa lambda, usually they are comparable. So for IgA nephropathy and lupus nephritis, when they are really characteristic, it's never a diagnostic challenge for pathologists. Oops. Okay. So that's the old study where we say years back on the IgA nephropathy. Now we look at the Oxford classification, which was published in 2009. Even in this Oxford group study, so the IgA nephropathy the definition was IgA dominant or co-dominant in the mesangium, in the glums, with mesangium or capillary wall staining. However, lupus-related nephritis should be excluded again. So we are trying to avoid the, trying to respect the boundary of lupus, the patients with lupus. And then the grading for the IgA is not as 2+ or greater, it's more than trace. On the other hand, still we commenting on C1q. So C1q staining, if it's more than trace, raises the possibility of lupus nephritis. So that's just a several time points review comparing with IgA nephropathy and lupus nephritis. Apparently, IgA nephropathy was kind of like treated as a new kid on the street back in the time of 1960s, 1970s, 80s, and even in the time with Oxford classification. So now we look at closer at IgA nephropathy. This is from Heptinstall Pathology of Kidney, which is the Bible of renal pathology. So in the book, we would say, okay, for IgA nephropathy, up to 45% of the cases, we can see IgG staining. And then up to 10% of the cases can show positive C1q. Well, the classical IgA nephropathy is IgA bright, C3 bright, kappa and lambda, both positive, but we may see lambda predominance or even lambda restriction, right, with a smaller percentage, usually less than 10%. So, and another study which look into just IgG staining in IgA nephropathy, they observed 200 cases with IgG staining out of a total of 627 IgA nephropathy cases. And of these 200 cases with positive IgG, only a small number of cases, they show either 2+ or 3+ IgG staining. So it's not common to see bright IgG staining in IgA nephropathy. However, it's not very common, right? So then the next question is there IgA nephropathy happening in lupus patients? Although, as we saw in the big studies, we are trying to avoid patients with lupus history. So there are reports in the literature. There are total 8 reports, and also non-lupus nephritis is recognized as an attribute to contribute to the ESRD in patients with lupus. So in the literature, there are total 8 reports reporting IgA nephropathy in patients with clear clinical lupus clear clinical lupus. Okay, and of interesting of these patients, one patient had 2 sequential biopsies. The first biopsy was called lupus class 2. However, the follow-up biopsy was diagnosed as IgA nephropathy. So with all these evidence, it seems we were trying to avoid or trying to respect the boundary of lupus for lupus patients. But it seems there are also, although really sparse evidence that IgA nephropathy may happen in lupus patients. And as we all know, that certain populations have higher incidence of incidental IgA deposits in the kidney, right? So I will skip these introduction for IgA nephropathy for our audience. And then for galactose IgA1 plays an important role in the pathogenesis of IgA nephropathy. I think I can skip this as well. So I will jump directly to this because this is very important for pathologists, because in this paper, this is the first article that identifying an antibody that can recognize or detect galactose-deficient IgA1 on kidney biopsy, or in other words, on paraffin-embedded, formalin-fixed paraffin-embedded sections, which that's how we process our clinical cases. So when we were reading this article, we were so excited about it. So in this paper, published in KI in 2018, so what they are presenting was KM55, which is a monoclonal marker or antibody recognizing galactose-deficient IgA1, can recognize the mesangial deposits in IgA nephropathy, which is primary IgA nephropathy, showing similar pattern and intensity to IgA nephropathy. And also similar results were observed in IgA vasculitis nephritis. But this KM55 staining was not detected in secondary IgA nephropathy or lupus nephritis. Okay, so for us, what's exciting is for the diagnostic challenge is IgA nephropathy versus Staph aureus associated infectious GN, because in those infectious associated GN, we would see bright IgA as well as C3 and kappa lambda. So which is a truly diagnostic challenge to distinguish between IgA nephropathy or HSP nephritis versus the Staph aureus infection-associated GN. And the other, gave us a hope to try this antibody, see if it will be able to distinguish incidental IgA deposition in patients without symptoms or versus the patients with truly IgA nephropathy with clinical symptoms. So that's kind of like giving us the hope with this when we were reading this paper. So we did the study, we got the antibody is commercially available. So we acquired it and then we did it in our research lab, but not in the clinical lab. And then while we collected our data, we did not see any differences between a Staph aureus associated GN versus IgA nephropathy or incidental versus symptomatic IgA nephropathy. And this is also observed by other investigators, as we can see. All these 4 following articles challenged the specificity of KM55 in primary IgA nephropathy or primary HSP nephritis or IgA vasculitis nephritis, right? So I summarized these articles. The first one, that's the one published in KI. So they looked into basically just a quick touch. So all the cases with primary IgA and HSP nephritis, they are positive for KM55. However, for the secondary or other cases they studied, none of them were stained. The follow-up studies, this is from Ohio group, and then they also confirmed that KM55 staining is 100% compatible with our IgA nephropathy and IgA vasculitis nephritis. However, for secondary or Staph aureus infection-associated GN, incidental IgA nephropathy is not conclusive, but they did observe the positive staining. So membranous was used as a control. And then there are 2 other groups of the study. They showed, okay, non-specific distinguishing between primary versus secondary IgA. More interestingly, even in the pediatric group. So they are also positive. Okay. And then the bottom are showing our, this is from the pediatric. Okay. So this is from another Chinese group. And then this is so basically that means we could not use this KM55 marker to distinguish primary IgA nephropathy and IgA vasculitis nephritis from secondary causes or distinguish from incidental versus symptomatic IgA nephropathy or Staph aureus infection-associated GN. What's interesting is the studies also included the cases with lupus nephritis. That's what I was interested in. And then all these cases, all these published data showed 100% identification of IgA nephropathy. And then when we compare the results for lupus, it's very interesting. 2 studies showed all negative staining for the lupus cases. And then 1 study, this is from Ohio group, about 40% of the cases, they are positive for KM55. But when we look at the staining intensity-wise, the median for IgA is 2+. For the lupus, although there are only 3 cases, it's 0, which means it's negative. And the highest 3 cases, 0, 0, and 1+. This is from a group from China. So in their population, they detect 100% positivity for KM55 of the lupus nephritis cases. And then look at their intensity. it has a wide range from trace to 4+. So I would not ignore the 4+ because that's really bright staining. Okay. So I think this is exciting is because it has variable conflicting data, inconclusive, right? So in our own lab, we did looked into IgA nephropathy. So we selected these cases. So 25 IgA nephropathy or IgA vasculitis nephritis cases, and then 20 cases with lupus nephritis. So these cases were selected. These are very classical cases. For pathologists, we would have no problem. We would call it straight out as either lupus nephritis or IgA nephropathy. And these cases, interesting, 100% of the cases, again, confirming the rest reported data. And also for our lupus cases, none of them has a staining, even trace. So the 3 cases of the 20 cases showed 0 to trace. Okay. So we use this as our foundation. We use this the data. So we felt very confident that the antibody in our hands, in our lab, that's how it behaves. So then we are wondering, coming back to the case I presented earlier, can we use the antibody to help us to tell if this is IgA nephropathy or lupus? And to the left, this is our KM55 staining, a positive control. So this is IgA nephropathy case in a non-lupus patient. So it is positive as expected. In our patient biopsy, it's completely negative in all the glums. So we felt we did not call it out straight as lupus nephritis, but we favored as lupus. Okay, so that's a kind of like the story of the background, how we our experience on the galactose-deficient IgA1. Basically, we use KM55 antibody to help to solve certain situations like this. Then coming back to the original question or other questions we reviewed, are there really IgA nephropathy in lupus patients? So because our case is quite bright for IgA, the only thing is that the IgG is also bright. So in this situation, we tried to search our data, see cases with, if we do not know the history, the patient has lupus. That's kind of like, it's a straightforward IgA nephropathy cases. So we identified a total of 11 cases from 10 patients. 1 patient had a repeat biopsy. Okay. And all these biopsies shows positive KM55, which is very consistent with the IgA nephropathy in non-lupus patient. So we feel this system, it is functioning as we expected. Okay, then the question is, so I'm not showing our own data as I mentioned about concerning to breaking the embargo, but we can show other information. So I don't know if I can move this around. Okay, anyway, so this is, these are the old reports in terms of, since we accept there are dual GN, right? And also there are reports, it's recognized that we have overlapping IgA nephropathy and membranous nephropathy. These cases can be readily recognized because by pathologists, because the membranous has a capillary wall staining pattern and it's IgG dominant. However, for IgA nephropathy, it's location-wise, it's in the mesangium, and then it's positive for IgA. So this is a unique pattern that's very helpful for us to recognize dual GN. So the question is, so it's reported in different population, sure. So the question is, do we have lupus membranous and IgA nephropathy overlapping cases? So these are exceedingly rare. We did find 2 cases. So for both of the cases, we see clear pattern of IgG at the capillary wall and IgA in the mesangium. As a pathologist, we do not have anything to hold back to call this, but we could not tell if the IgA is just incidental IgA or it's also causing symptoms like for the hematuria or contributing to the proteinuria, but the patient has membranous nephropathy already, so the patient has large amount of proteinuria. But interestingly, both cases, they are positive for KM55. Okay, so these two cases, although it's a really small number of cases, but they do provide strong evidence, direct evidence that in lupus patients, we can see the coexistence of IgA nephropathy and lupus nephritis, right? So the next question is, for the cases with loaded immune complex deposition involving both mesangium and capillary wall, which we would, with bright C1q, tissue ANA extraglomerular deposits, and then tubular reticular inclusions detected by the EM. Are any of these cases actually are dual GN with some IgA nephropathy component? So that's the question. So we selected these cases by using the criteria, say IgG and IgA codominant. Either they both are 3+, or the IgA is slightly brighter than IgG, say 3+ of IgA and 2+ for IgG. But the rest fits perfectly for lupus nephritis. And then we identified 19 cases, and then surprisingly, but also very excited, we are very excited about the results that about 10 cases out of the 19 showed positive KM55. If we trust our system that using the threshold to call IgA nephropathy in the lab. So we feel like, yes, we're entering into a field that it's unknown or unrecognized before. So that's why right now we moved our KM55 staining from basic research lab, we developed it in the clinical lab. Okay, so now I would do any staining for these cases with challenging, where features a codominant IgG and IgA or IgA brighter than IgG. Okay, so then is there any background information that could explain this? So from the genetic studies, there are reports with conflicting results. So what are certain results showing no overlapping genes that are shared by IgA nephropathy and lupus nephritis. However, there are other studies showing that they do have shared genetic changes. Okay, or genetic susceptibility. All right. So then the quick summary for what our experience with this KM55, we feel is a valuable ancillary tool when we read kidney biopsies, especially in patients with lupus. And if our interpretation is if it's negative, it's just lupus. And then for lupus, when they are showing codominance then of GNA, we would do KM55 to recognize if there is coexistence of IgA. That way we reported it, we documented it, and then we would like to follow up and then further management. I think those are going to be our future studies and then possibly genetic studies. So lastly, I would thank all my colleagues. So Dr. Kim is at U of M and he's pediatric nephrologist. And then Dr. Nast at Cedars-Sinai. So we collaborated collecting some of the cases. And Dr. Lai at Chinese University of Hong Kong and Dr. Zhou in Texas. And then also my student Bayardo. He is a very brilliant MD PhD candidate. Okay. Thank you. That's all I was going to share, and I'm happy to take any questions or have any discussions on this. So.
Thank you very much, Dr. Bu. That was a great that was a great presentation. I think you nicely summarized a lot of the issues that we also encounter in our renal biopsy service, where we have a lot of overlap between IgA nephropathy and other entities. We also have a very large Asian population in Vancouver, so there's always the question of incidental IgA with the addition of another entity, or if the IgA is significant. So,
Right. Yeah.
so are there any questions?
Sean has a question. I'm just going to allow him to talk.
Hi, thanks for that interesting presentation. I agree, it was really interesting to see with Yuzuki's group publish that initial report on the KM55 antibody, because it was one of the first times to demonstrate galactose-deficient IgA in the actual tissue. And in his report, it seemed to be very specific for either IgA nephropathy or IgA vasculitis, and secondary IgA nephropathy cases, for example, due to cirrhosis, seem to be negative. But then, as you mentioned, subsequently in other studies, for example, in Brad Rovin's Ohio group study, KM55 actually seemed to be positive in not just IgA nephropathy that's idiopathic, but also in secondary disease. And so it seems to be the more that's published on this, the less specific we can say that KM55 is for idiopathic IgA nephropathy in any event. And so I guess I'm wondering, if you're going to move this into the clinical domain, is there a risk that using KM55 to infer the presence of idiopathic IgA nephropathy may become problematic? And then do we need to also focus on the IgG antibodies in terms of some studies have attempted to elute the IgG antibodies to determine, are they actually targeting galactose-deficient IgA? Are they the anti-glycan antibodies that represent the HIT2 in IgA nephropathy? Or, such as in lupus, would they be more directed against anti-nuclear proteins or other proteins?
Well, these are great questions and great comments. Thank you. So let's come to one by one. Hopefully I remember all of them. So first question, yes, I agree with you. Actually, as we saw, even in our own hands, we observed similar results. So we could not, we see KM55 staining in secondary cases. We did, almost all of them. The question is, so in the patients with lupus, are we detecting only idiopathic? For sure, no, I don't think so. And even if you ask me, do we know if what we are detecting, what we are seeing, say, are we interpreting the KM55 positive lupus biopsy cases as incidental IgA purely, or they may be real IgA nephropathy? The answer also, I'm not sure. But for the cases we had of these 11 cases, 11 biopsies from 10 patients, we do have a patient have, the first biopsy was 3 years after diagnosis of lupus. And the first is purely IgA. So this is IgA in lupus patient. And then the follow-up biopsy, there are 2 more follow-up biopsies. The second biopsy does not have much material. So the third biopsy was done 28 years after the diagnosis of lupus. The patient does have lupus symptoms, has been following up with the rheumatology department. But the KM55 are positive. So could this be incidental? I would say the biopsies were done because of the hematuria and the proteinuria. So it's not purely incidental or no clinical symptoms at all. On the other hand, the patient has been doing so well, right? Yeah, the follow-up 28 years after diagnosis. But on the other hand, of these 10 patients, we do have 1 patient who had the biopsy, I don't remember, 1 or 2 years after diagnosis of lupus. And then the patient progressed to ESRD 5 or 6 years after the diagnosis, after the kidney biopsy. So I think what we are detecting, again, just confirming what you're saying, yeah, it's a mixture of maybe not, is maybe behaving more like indolent IgA nephropathy, and also we are detecting the cases that cause ESRD, that's progressive IgA nephropathy. So that's one question. I forgot what else you were asking.
sorry, my second question was just about do we need to go after the IgG antibodies and further the science on eluting those antibodies to demonstrate whether they're targeting the galactose-deficient IgA and sort of represent the second hit, or are they targeting other antigens that may represent two processes?
So may I clarify, do you mean the to elute the IgG from the tissue or from the serum?
I was proposing the tissue, which is, I think Jan Novak has done some preliminary studies on this. I don't think it's very technically easy to do, although I'm not a translational scientist, so I can't really comment on that per se. But I know that it's been tried, you know, in terms of demonstrating whether the tissue IgG you're seeing, for example, in a lupus case, is targeting represents anti-glycan antibodies or represents other target antigens that might be present in lupus?
That's a great question. Honestly, to be candid, I don't think I know the answer, but I do have some comments. So talking about to elute the IgG from the tissue, I think that's very challenging. And then practically, I think for research-wise, it's doable. For more to see if it has a clinical impact, I do not think it's very practical. And on the other hand, as we see, I think I put in, IgA. So we do have a good number of IgA cases with positive IgG. However, for the cases when we call straight out as IgA nephropathy in lupus patients, actually none of these cases has IgG staining by routine IF. That's number one issue we are facing. Because as a pathologist, we would not risk to say, okay, this could fit better, or if this doesn't fit perfectly for IgA nephropathy, we would not risk, because you know the background. We are trying to respect the boundary of lupus. So then we would not call this IgA nephropathy in a patient with lupus. That's number one. And then number two, for the IgA deposits, our study which I didn't mention about is we did some study on the galactose-deficient IgA1, even in IgA nephropathy native cases, also in the transplant patients. So certain patients, they have this deposits for many years, and then their kidney allograft function maintained. So we are not sure when we look at this multi-hit pathogenesis pathway. So it's kind of like one possibility is immune complex were formed and then deposited in the kidney, right, causing injury. However, it's also possible, or it's not ruled out, that the galactose deficient IgA, they were directly deposited in the kidney. And then if they are forming the immune complex, they might be formed in situ within the mesangium. So that's another possibility. And then to make it more complicated, so the immune complex, it can be IgA type or IgG type, right? So, and then for the ones with IgG, and mostly for IgG subclass staining, there are predominant IgG1. And then for lupus, it's IgG1 can be positive. So unless, as you said, we do really for the basic science to figure out which target the IgG1 is targeting at. Yeah, I do not have an answer to that. Yeah.
Also have a quick question. So you mentioned about the looking at post-infectious cases and definitely mentioning the secondary causes of IgA. Do you know if you or any other of the studies particularly looked at IgA dominant MPGN cases?
I had two cases. So for our own, we look at IgA, okay, not for our own, our N number was small. So that's why actually we didn't write the manuscript while we were still waiting to accumulate more cases. So go back, we're here. So great question. We tried two cases of MPG and IgA, they are positive. And then I tried one IgA, okay, IgA mono MIDD case is negative. I tried IgA with lambda restriction. It's a positive. I had 2 cases of that. And then I had 1 case with kappa restriction. It's also positive. So I had another weird case. It's IgA immunotactoid. It's also positive. And then tumor associated, also positive. And then even the tumor associated with the thrombi is a bright positive. So I think we cannot use this to distinguish from other entities so far. I do not feel comfortable with that. But that's just based on our limited experience. We have small number of N, as I said, yeah.
Now that's interesting. As Sean mentioned, the longer an IHC stain is out, the more staining people do, it definitely changes the sensitivity and specificity.
Yeah, absolutely. Just the same as any other marker, right?
Yes. And so are there any other questions? Okay. If not, then we'll go ahead and thank you very much, Dr. Bu. And it was a great talk. Thank you.
Thank you. Thank you for your time. Okay. Bye.